So for this video, we're going to be looking at two miscellaneous special tests, one for the AC joint and one for the biceps. The first is what's known as the shear test for the AC joint. The second is what's known as the speeds test, which is helpful for identifying a pathology involving a tendon of the biceps. So let's go ahead and dive in. For our first test, it's called the AC shear, and specifically what we are trying to do is create a shear force, essentially a force that instead of being parallel is perpendicular, and that's going to occur through the clavicle and the acromion. And so for this, what we're going to do is create essentially our hands into this position with our anterior hand, the thenar eminence, contacting kind of right through the anterior shoulder, but also our hypothenar eminence on the clavicle. Our posterior hand is going to contact the spine of the scapula. And then once we're in that position, we're going to essentially create compression. What that does is create a shear force, again, through the acromioclavicular joint, and can give us some indication if that joint is hypermobile or has been disrupted. So, if we're to do this, again, our setup is anterior hand here, posterior hand along the spine of the scapula in the back, interlock the fingers, and then create compression. Now, if it's positive, because we are really right at the AC joint, our specificity is actually quite good. It's greater than 0.9. If it's negative, well, that doesn't really tell us a whole lot. Sensitivity is rather low on this test, so use it with a grain of salt. The second test is what's known as speeds test, and again, it's helpful for identifying a tendinous pathology of the biceps, specifically long head of the biceps. For this, we need to set up our patient in a way that's going to bias towards that long head of biceps. And so the position is they're going to start with their elbow in full extension, arm at their side, and in a fully supinated position. So we'll start here. From this position, they're going to go from 0 up to about 60 degrees of shoulder flexion while resistance is being applied by the clinician. Now, because this is not a test of muscle strength, but is more of a provocation test, we actually can cross multiple joints. And so typically where the resistance is applied is more into the distal forearm. We're going to have the individual sit up nice and tall. We'll stabilize proximally, and then we'll say, we want you to come up to this position right here while we provide resistance. So when you're ready, go, 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 go. Excellent. Right? Now, while this is helpful, you can do a couple other things to give you a little bit more specificity for the test. One, while you're stabilizing proximally, you can also be palpating that bicipital groove to be a little bit more specific to the tendon. Additionally, you can ask questions or do some other kind of clinical reasoning within your subjective history to identify that the biceps may or may not be involved. In either way, as the test is demonstrated, both sensitivity and specificity are not great. Specificity is about 0.75, so it's okay, but not fantastic. So again, don't use this as an isolated test, but rather combine it with all the other factors that you're collecting as part of your clinical exam. So have a go with a peer or colleague with these two tests, and let me know if there's any questions.